So anyway, he ended up clearing, and we were able to find that out because we kept in touch with him, and and he was engaged with us. So that's tied in again to the innovative research, innovative service idea. I'm going to move past this a little bit because I do want to be able to share with you some of the data, but I really do want to emphasize that one of the main things that I think we found through doing our research is this breaking down of social stigma and social marginalization of drug use. So in our research, when we're doing our interviews, if people have questions for us about our own drug use or our own experience with squatting or our own experience going to the movies or whatever it is, we feel like it's really important to break down some of the traditional formal boundaries that are there, and begin to normalize conversations about drug use and about hepatitis C so that we can kind of have these individualized relationships and move from that point. What we found in the research, real quick, we found that at the initial testing, about 60-40 in terms of positive, negative to positive. We've detected about 25 new infections, so prospectively observed. They were negative when they started our study and at some point became positive. About 14 of those were short intervals, so that means we had blood directly before they became infected and then right after they became infected, and we're able to follow them. We've also been able to offer, I think, 5 or 6 of them treatment, and they've successfully cleared because we know that treatment is more effective if it's within the first 6 months of an infection. We've also had, we've been able to detect 19 window period infections, so people who were antibody negative but viral positive when they first came to us. 14 possible reinfections, because again, we're following people who are antibody positive from the beginning, but viral negative. And we found that a handful of those 14 people have become reinfected at some point, some of which have cleared and some of which have not re-cleared the virus. And 3 self-reported seroconversions. So that means they were antibody positive and viral positive upon coming to us, but reported that sometime within the last 3 to 6 months they had had a negative test. And so we worked with them. So what you can see in terms of our incidence data, the main points that I want to point out from here, it's kind of volleyed a little bit in terms of year-to-year incidence around Hep C incidence rates. There was a big drop between 2006 and 2007, then again between 2008 and 2009. If you look at the confidence intervals, there is some overlap, so we can't tell yet whether this is totally due to chance or whether or not it's statistically significant. But if you look at the confidence intervals and the incidence between 2005 and 2007, then again 2008 and 2007, it does look like it could be statistically significant in terms of some of the reductions in incidence. 2008 was a big increase, which we'll talk about very, very briefly in a second. The other piece that I wanted to point out is in terms of follow-up, if someone's going to become infected, it looks like it's much more likely to happen within the first 60 days of their enrollment in our study. If they've been in the study for 60 days or more, it looks like there's a good chance, it's less likely that they're going to become infected with hepatitis C. So looking at the decline after 60 days of participation, there's a few different reasons why that could happen. It obviously could be because people who are higher risk may either become involved sooner in the study, they may need money quicker, certain resources available, or they could actually fall out of the study sooner, which means we wouldn't detect their infection later on. We'd also like to think that there is something to be said for the actual intervention. The intervention being both the services that we provide, as well as just the act of engaging with someone on a weekly to biweekly basis, talking about their risk in a very honest way, talking about that it is possible to prevent the transmission of hepatitis C, to talk about risks, to have people constantly sort of thinking about what their risk is and engaging with themselves and with other people and with each other also. And in terms of the changes by calendar year, we moved locations in 2008. That could also kind of speak to the spike in 2008 in terms of why there was a greater incidence. We're not sure yet exactly what that was about, but there's a number of reasons why the incidence rates could have changed. So to conclude, a couple of notes from the field. Prevention is not only about messages. So we can tell people over and over, and we see them weekly or bi-weekly, about sharing cottons, cookers, waters, syringes, things like this. But there's also got to be access to the information and interest. So if people, one, don't want to go to the syringe exchange program or the program for whatever reason because they may feel judged or they may have some issues around why the program doesn't meet their needs, then it doesn't matter if the services are available. And there's also got to be a self-interest in taking care of oneself. So we see lots of people who come in and say, well, I'm just going to get hepatitis C. I don't really, it's not an issue. And so working on that, building up self-worth, and really showing interest in people's lives, I think is critical to actually preventing hepatitis C. Building strong relationships is essential. The relationship is the crux. If we can't talk to people, then we can't share all this information that we're doing all this great research to find out. And people need to trust each other to talk about their risk and their feelings. Destigmatizing drug use, I think, is huge and so critical. And that's destigmatizing drug use both with provider-client relationships, but also just, people carry out their own weight around their own behaviors. And the more that we can work to break that down, I think that's where we're really going to see, changes in terms of hepatitis C infection rates. Low threshold services make it as easy as possible to get what you need as quickly as possible, and then, go out and do your business that you need to get done. Location was really central for us. We've seen some significant shifts in people attracted to the program as our locations have shifted a few times. Timing, engaging in conversations when people are ready to hear them. We're not trying to change anybody's minds or behaviors, but we're available whenever people want to come and talk to us about things that are going on. And more comprehensive testing. People need to know their status, and people need to understand what their status actually means to them. So antibody positive, viral negative, all of the different sort of nuances with hepatitis C. It's complicated for a lot of people who've been studying it for a long time. It's especially confusing when people are just kind of given this information but don't really know what it translates in terms of their own health. So that's our project. That's our small, humble staff in our old space. And I just wanted to put some acknowledgments out there. And my contact information in case anybody has any questions. So, thank you very much.